We spoke about vaginal bleeding in patients that are not pregnant. For the next few minutes, we're going to talk about how we approach vaginal bleeding in our patients that present to the emergency department with a history of bleeding. And so what we'll do is we'll talk about the role of ultrasound, and it is usually the first line modality for the examination of these patients. We'll explore the different causes of bleeding during the first, second, and third trimester, and focus on some of the key ultrasound findings that allow you to make a specific diagnosis. So here's our list of potential causes for vaginal bleeding. You can see here it's divided under first trimester and then second and third trimester. Obviously, in the first trimester, the most common causes of bleeding are going to be due to bleeding during implantation early on in the early part of the first trimester, what we call a subchorionic hematoma. We'll talk about failed pregnancies, ectopic pregnancies, and a discussion about molar disease. And of course, in the second and third trimester, we focus more on the placenta and looking for problems with the cervix. So here's our first case. 24-year-old presents with vaginal bleeding, estimated to be 7 weeks gestational age. And here on our transvaginal scan, we can see the gestational sac. We have an embryo, and we can appreciate that there's a heartbeat on the M mode. One of the other things that we'll notice is that we have this hypoechoic collection right behind the gestational sac. Looks like it's even flattening the sac a little bit on this image. So what we have here is this collection, which is obviously going to represent a subchorionic hematoma in a patient with threatened abortion. So patients who present first trimester vaginal bleeding, by definition, that is a threatened abortion, and it is the most common abnormality that we see. This is the most common reason that patients present with vaginal bleeding in the first trimester. And we say it occurs in at least a quarter of patients. Now, most of the time when these collections are small, the prognosis is very good. They will resolve. And the patients are usually told to take it easy, go to bed rest, not to exacerbate the problem with the bleeding. So as long as they're small, and we don't have real size criteria, we sort of guesstimate, if it's a relatively small focal bleed, that patients will do well, and obviously we will follow them. But when we have larger bleeds, as we see here, that may deface the gestational sac or cause compression of the sac, then obviously we're concerned that the patient is going to have not as good an outcome. And here we see two examples of very large hematomas. This one on the left-hand side obscures the gestational sac. We just see it as a large hematoma. And then we have another one here that's easily as large as the gestational sac and appears to be displacing it. So these are pretty straightforward diagnoses. Again, the diagnosis should be made by our sonographers because they're going to identify them. They're going to capture them. They'll even put cursors on them to give us a sense of how big they are because our obstetricians are going to want to know how big is the bleed. And what about this case? Here's a 30-year-old had a last menstrual period about 6 weeks ago, has some vaginal speeding, and so they are asking, is this a viable pregnancy? And so we have this static image on the left-hand side shows this echogenic mass within the gestational sac. And you can see here in real time, you may not appreciate, it looks like there's flow around the periphery of the mass. You can see just this vascularity around the periphery here. So what is this? This is something that's interesting. We didn't really talk about, more than 10 years ago, but now it seems to be almost a common finding. We see these not infrequently. This is called a chorionic bump. Maybe it's due to the improved resolution of our scanners that we see them more commonly now than we used to. The origin of these bumps is uncertain. Articles have said it's either related to a subchorionic hematoma that projects into the gestational sac, or perhaps it's related to a vanishing twin. We're really not sure. It's, according to the literature, it's less than 1% of pregnancies, but like I said, we see it more commonly now than we used to. It has an association with infertility treatments, such as IVF, and it has a guarded prognosis, as it does suggest that the patient is not going to have a successful pregnancy. Here's a case of a 30-year-old with a history of an intrauterine pregnancy presenting with vaginal bleeding and a falling HCG. And looking at this transvaginal view, we don't see a gestational sac. What we see is maybe a little bit of hemorrhage within the canal, but the canal looks relatively thin. One of the things I will do is I will put color on that. And I will put color on the lining to look for evidence of any retained tissue. And here we see no evidence of any vascularity associated with the endometrium, just a little bit of blood, a little bit of fluid within the canal. The endometrium itself looks relatively thin. And so in this case, I think it's fair to say it's a complete abortion. There's no evidence of any tissue remaining within the endometrial canal. But contrast it with a case like this. And again, whenever we have these patients, and even if they know it's a failed pregnancy, their first question is, are there retained products of conception? And that could be a challenging diagnosis to make. So here's a 27-year-old with a history of bleeding, and here they assess for pregnancy, right? It's a positive pregnancy test. Is it an intrauterine pregnancy? Do we have an ectopic pregnancy? What's going on? Patient's bleeding. And here we're looking at the transvaginal scan, sagittal view of the uterus, and we see irregular thickening of the lining. And so, how much of that is blood? How much of that is residual tissue? In the acute situation, the color Doppler can be very, very helpful. Here we see areas of increased vascularity associated with this irregular thickening of the endometrium. And when I place a sample volume on it and do my pulse Doppler sampling, I get a velocity that's just about 40 centimeters per second. So what is the significance of that? What the significance of that is that it's telling me there is some retained placental tissue in this patient. And we'll go over that a little bit. So a little bit of tissue there, it has increased vascularity, and we can call that some retained tissue in an incomplete abortion. So just to spend a minute talking about pelvic Doppler studies, there are a number of benefits, a number of different applications where color and pulse Doppler can be very helpful. I mean, one of the obvious applications is certainly ovarian torsion, and knowing how to interpret the signals that you get from a patient with unilateral pelvic pain and in an abnormal ovary. In this situation, we're talking about evaluation for retained placental tissue. It also helps in the evaluation of ectopic pregnancy, looking at the corpus luteum, and obviously in characterizing uterine and adnexal masses. But let's just focus on pregnancy. And, what are we looking at? Well, early on in pregnancy, as the developing placenta or trophoblast grows into the uterine tissue, it invades into the maternal spiral arteries. And those spiral arteries will then shunt blood into the intervillous space, which is depicted in the illustration on the right. And you can see here how those vessels are shunting blood that is low resistance. It's filling the intervillous space to provide blood flow for this developing pregnancy. And we can characterize this increased blood flow around the early gestational sac as early as 5 weeks after the last menstrual period. So that's the cutoff. After 5 weeks, you should be able to see that. Now, we don't routinely do this in normal intrauterine pregnancies because of the concerns of the increased energy that you'd be putting on an early pregnancy. But I do use it when I'm looking for evidence of retained products of conception. So after 5 weeks, we will see it. And if we place the sample volume in those vessels and we get a velocity greater than 21 centimeters per second, that is consistent with retained placental tissue. This is a very easy thing to do. It's probably underutilized in our practices. This came out of studies that we did at Yale 1990, and it's held up all these years. It still works very, very well. The one caveat you have to remember, or at least tell your sonographers, is that they need to use a 0-degree angle. These vessels are too small to determine the direction of blood flow. You can't tell the direction of blood flow in these tiny vessels. So if you put a 0-degree angle, you will still see that frequency shift to know that it's greater than 21. It works really well. So let's take a look at this case. This is just one example, that I've had where it really is helpful. You look at this case, 34-year-old, vaginal bleeding, positive pregnancy test. Where's the sac? Maybe it's an ectopic pregnancy. In fact, I have trouble even, the endometrium is really not that well defined. But you wouldn't say there's an IUP here. And you probably have to be spending your time in the adnexa looking for evidence of an ectopic pregnancy in a patient who has vaginal bleeding. But just turning the color on, you can see here there's this whole focus of vascularity along the posterior wall of the endometrium. This is the retained tissue that is obscured on the grayscale image. And if you sample that, there's very high velocity flow here. You can see that the velocities are over 120 centimeters per second. And think about that. That's a 0-degree angle. And that's very, very high velocity flow. So again, that's telling me where the retained placental tissue is, even though I really couldn't define that on the grayscale image. And again, just pointing out it's a 0-degree angle, and that's the key to making it. If you use a 60-degree angle, because we always think, oh, it has to be a 60-degree angle, you will inflate that velocity too much. So you have to have a 0-degree angle in situations such as this. Now, 24-year-old pelvic pain spotting, one of the things we're always concerned about is ectopic pregnancy. So we want to get a really good look at the uterus, at the endometrial canal. Here we see on the left-hand side, beautiful view of the uterus, transvaginal, sagittal view. We see the endometrium. There's no evidence of an IUP. We look in the anexa, and we can see the right ovary in the middle, and then we have the left ovary on the right-hand side. We see the follicles. These are ovaries. But what also do we see? We see this little round, ring-shaped structure on the right side, adjacent to the right ovary, classic appearance for an ectopic pregnancy, and a little bit of free fluid around it, obviously leaking from the fallopian tube. So this becomes a very straightforward diagnosis. This is the classic example of an ectopic pregnancy, seeing the ring-shaped mass, looks like a donut. And here's another example. Sometimes we'll see a live ectopic pregnancy. If we see the heartbeat, that makes it easy. We only see that less than 10% of the time. But again, looking at the adnexa on the left-hand side, we see this well-defined gestational sac. We can see the yolk sac very well, and it has a little tiny embryo. That's the diamond ring sign, right? If you place the M mode in it, you can see that there's cardiac activity. You can also document it, with a video clip, and you can see all the blood around it in the adnexa. Now you're saying, well, where is that? This is all blood in the tube. That's a hematosalpinx. Here we have this sort of cigar-shaped structure filled with blood. That's the hematosalpinx, and you can see it's adjacent to the ovary there with the follicles. So again, seeing the live embryo there is very helpful for them. It certainly tells them how to adjust their management. They may not necessarily give methotrexate. They may decide to go and do surgery. Again, another classic adnexal ring. Unfortunately, we don't see this all the time. Many times what we just see is the hematoma or the solid adnexal mass. But again, making sure that our sonographers are looking for the adnexal ring. You can see the hemorrhage around it here. This is a bleeding ectopic. And also notice that there's blood within the uterus, in the endometrial canal. We have a fluid level there. This is what we call the pseudogestational sac. Right? It's a very thin lining, and we have all that fluid in there. Now, that's a term that people don't like to use, the pseudogestational sac, but I think it's important that when we see that, we say, this is not the pregnancy, right? This is just blood inside the endometrium from a leaking ectopic pregnancy, which is well seen in the adnexa. And there it is. So, uterine findings, of course, in an ectopic pregnancy, it should be an empty uterus. The endometrium may be thin or it may be thick, depending on hormonal stimulation. Sometimes we'll see some endometrial cysts, and we may see fluid in the canal, as we did in that last case, which can be called a pseudogestational sac sign. In the adnexa, of course, we're looking for the donut or the ring-shaped mass, but many times what we're seeing is a solid mass. And one of the clues is that the ectopic pregnancy is typically more echogenic than the ovary. That is something that's very important, because a lot of times people say, oh, well, is that an ectopic? Is it the corpus luteum? I really can't tell. Ectopic pregnancies are typically more echogenic than the ovarian parenchyma, and that's one of the signs, and you can see that here in this case. The ectopic is brighter, and that's helpful. And of course, we're looking for free pelvic fluid. Obviously, a small amount of fluid isn't that helpful because it could be from the corpus luteum, but if we see a pelvis full of blood, then we know. Is color helpful in identifying ectopic pregnancy? Well, usually you don't need it because we're looking for the mass, but every once in a while I'll have a case like this. If you look at the image on the left here, where's the ectopic? What it looks like is a little bit of tissue here, relatively hypoechoic. I'm not really sure. Could it be blood? Could it be bowel? It's tough to say, but when I turn the color on and I see the tissue light up, I know it's not blood. I know it's not bowel. In this case, this was a ruptured ectopic. So every once in a while, the color will help me identify it where it's not a classic appearance. So I think most of us are very familiar with the sites of ectopic pregnancy. Most of the time, over 95% of the time, it's going to be located in the fallopian tube, usually on the ampullary end. That's why it's close to the ovary. But we also have to keep in mind that they can occur in other locations, although less commonly we get very concerned if it's an interstitial pregnancy, a cervical pregnancy, or a cesarean scar pregnancy. And we're going to touch on those. So here's a 38-year-old status post-IVF, and vaginal spotting, and we're looking at for the pregnancy. And here, this is a sagittal view of the uterus. So it's sort of moving out to the side, and we see this ring-shaped mass. Now, where is it? Is it in the uterus? Is it outside the uterus? That can be tough. So obviously, we need multiple views. And here is the transverse view. So clearly, it looks like it's in the uterus, but it's very peripheral, right? It's all the way out to the side. Now, the key to this case is where's the endometrium? Here's the endometrium. This sac is not in the endometrium. This is an ectopic pregnancy by definition. Regardless of its location, this is an ectopic pregnancy. Now, the location is important because the site of it is going to determine how it's going to be managed. Is it going right to surgery? And if we think it's in the uterus but not in the endometrium, then it's very concerning because the risk of rupture is very, very high. And that's going to cause a significant problem if it does rupture to the patient. So where would we call this? Well, we would call this an interstitial pregnancy. It's in that portion of the tube inside the uterus, outside of the endometrial canal. So this does occur. In fact, because we see a lot of ectopic pregnancies, we see it not uncommonly, but it is a very, very challenging diagnosis, right? Those of you who see these cases know how hard it can be, and frequently you'll say, well, we need another test. Maybe we need to get an MRI or something, because you're really not sure. But again, if it's outside the endometrial canal, it is indeed an ectopic, and it's likely an interstitial pregnancy if it's in the uterus. Now, of course, the concern is massive hemorrhage. So how do we decide if it's an interstitial pregnancy or not? Now, and if you look at the literature, they have these measurements, 5 millimeters, 10 millimeters. They don't work at all for me. I don't use measurements. And then there's the interstitial line sign, which I think is really an imaginary sign, because you can imagine an interstitial line sign when you see a sac separate from the endometrial canal. But regardless, here's the endometrium, here's the sac. It's not in the endometrial canal, it's an ectopic. This is an interstitial pregnancy, and it's bulging, it is concerning. So although we have these signs, I think the thing that you need to do is determine, is it in the endometrial canal or not? Sometimes color coding the images can be very, very helpful. What I do in my practice, which makes a tremendous difference for me, and it's not hard to do, is a 3D image. Most of our machines now do 3D reformats, and it's so helpful to determine where the sac is relative to the endometrial canal. Now, here are the definitions that are currently accepted, certainly in the OBGYN community. It's funny, they consider a cornual pregnancy to be an eccentric gestational sac in the horn of a bicornuate or septate uterus, something that's not, it's in the endometrial canal, but it might be in a uterine anomaly. I mean, they understand when radiologists say it's cornual that they mean it's interstitial, but it has a specific meaning. An interstitial pregnancy is that pregnancy that's located within the fallopian tube outside of the endometrial canal. Now, what's important to distinguish from is an angular pregnancy, and I know many of you have heard this before. It's within the endometrial canal, but it's located in a eccentric area, right? It's usually superolateral. It's not central where you'd like it to be. It's off to the side. It's lateral, and it looks like it could be an interstitial pregnancy. So that's the terminology, and I think we have to be able to try to decide what we're looking at. So here's a case of a patient that presents with this sac that's very eccentric. It's all the way out to the left side. You can see the corpus luteum here. Here is the sac. Is it in the canal or not? That's the thing that has to be done. In cases like this, I will always do the 3D. Now look, if I measure this myometrium here, it's probably about 5 millimeters. And by definition, that would be an interstitial pregnancy, but it doesn't always work. It is so operator dependent. You can make that measurement any which way, and so I don't rely on that. But if I do the 3D, I can see, it's exactly where I think it is. It's in the endometrial canal. It's an angular pregnancy. It's not an interstitial pregnancy. Here's another example. 35-year-old presents with vaginal bleeding, positive pregnancy test. Look at this transverse view. Here's the sac. It looks like the endometrium is all the way on the other side. What does that mean? Well, it's either an interstitial pregnancy or maybe there's a uterine anomaly. I think those are the things that you have to be thinking about. Because, why is the endometrium all the way off to the left and this sac is all the way over to the right? So you really get to have multiple views. If I look at the sagittal view, well, it looks like it could be in the endometrial canal. But the answer is delivered easily when I do a 3D. And here is the 3D. It shows me it is all the way off in an arcuate uterus. So you can see the endometrium really well here. It's within the endometrial canal. It's an arcuate. And I think it's important, and you can see the little indentation. The fundus is intact. I think it's really important to understand the classification of uterine anomalies. There's a number of classifications, but what I want you to focus on is that most anomalies are either an arcuate or a septate. Although radiologists like to call everything bicornuate, that's less likely. It's usually an arcuate or a septate uterus. That's what you need to be thinking about. You need to see the fundus to determine that. Now, I'll show you the exception to the rule. Here's a patient, again, you could see that here's a little bit of canal here, echogenic area on the right, and then we have the sac on the left. Again, what are we dealing with here? Again, it's hard to tell on this. You might need to go to an MR. If you don't have 3D capability, then MR is going to give you that coronal oblique view so you'll be able to tell. Because in this case, this is a sac in a bicornuate uterus. And you can appreciate here that there's this cleft. Bicornuate uteri have a cleft at the fundus. You have to see the fundus to be able to determine that. And again, it's less common than the arcuate and the septate. What about these other types? Here's a 35-year-old pelvic pain and bleeding, positive HCG. Where's the sac? Transabdominal view can be very helpful. Again, gives you a global view of what's going on in the pelvis. Here's the uterine fundus. There's the sac. It's really low. So, we want to get a closer look. We do the transvaginal scan. Transvaginal scan shows us it's in the cervix, all right? Again, another place you don't want to have a pregnancy because of the risk for massive hemorrhage. So you identify it, you characterize it. We can see that there's a yolk sac. We see there's an embryo. This needs to be treated urgently. There's a number of different ways of doing that. Sometimes it's surgical, sometimes it's interventional, but it has to be addressed immediately because for the risk for severe hemorrhage. Again, not that common, but we do see them, and you have to be aware of it. Risk factors include prior abortion and instrumentation, and you can see the sac and even an embryo in the cervical canal. The differential diagnosis would include a spontaneous abortion, but you usually don't see a live embryo in that situation. I've seen it, it's rare. So usually what you'll just see is the tissue that is moving through the canal in a patient that's aborting. What about this one? Vaginal bleeding viability. This is slightly different. Again, it's a low-lying sac, but notice its location, very anterior. And when we get a close-up view, we notice it's at the level of the lower uterine segment. It's adhered to the anterior uterine wall. And you notice that the uterine myometrium there is very thin. So this is obviously related to what? This is a cesarean scar pregnancy, something that we have to know about because of the fact, again, not for the risk of rupture, the risk of heavy bleeding when these sacs implant on the myometrial defect of a patient that had a C-section. And there's also a relatively high risk of placenta accreta. All right, a couple of other things that you may or may not see. 31-year-old, positive HCG, vaginal bleeding and pain, and look at the uterus. Well-defined gestational sac. We can see the yolk sac, little embryo there. Are we done? Well, not exactly. Didn't really explain the vaginal bleeding and the pain yet. I don't see a subchorionic hematoma. But what I do see is an additional sac out in the adnexa. So this is a heterotopic pregnancy. So again, these can occur, but not very common. It really depends if they've had in vitro fertilization or some other assisted reproductive treatment. That really does increase the risk from 1 in 30,000 to about 1 in 500 or less. So, having that history of assisted reproduction treatments makes you more concerned about a heterotopic pregnancy in these patients. And you'd like to know how many embryos were implanted. If they only implanted one embryo and you see an IUP, well, then they're not going to have a heterotopic. But if they implanted multiple embryos, then that risk does exist. So again, think about patients that had procedures, history of PID and prior ectopic also will increase that risk. All right, moving on. Here's a 15-year-old with vaginal bleeding and vomiting. And so we have a positive pregnancy test, and what we see is this large heterogeneous mass in the uterus. Interestingly, if you look at the adnexa, we see enlarged ovaries with multiple cysts. So I think the appearance here of this mass with all these little cystic changes and these cystic ovaries should point you to the fact that we're likely dealing with a mole, and what we're looking at in the adnexa are theca-lutein cysts related to this molar pregnancy. So although uncommon, They are associated with uterine bleeding. And again, it's a pretty classic appearance of having this heterogeneous mass in an enlarged uterus. And this is related to the proliferation of trophoblastic tissue. And again, if you get an HCG level, I mean, they're usually sky high, right? They're way out of proportion to the dates, way out of proportion to what you're seeing on your scan. So that's always very, very helpful to know what the HCG titers are. And as you know, there's two types of mole. There's a complete mole and a partial mole. For the moles, we typically will see these cystic changes, right? The uterus is enlarged, endometrium is expanded with all of this tissue, and the placenta is irregular and thickened with increased vascularity. And as I mentioned, you'll see the theca lutein cysts. If it's a complete mole, again, we see it as a relatively solid mass with cystic changes. There's no fetal tissue. If it's a partial mole, then we do expect to see some fetal tissue. And in this example here, you can see the gestational sac and then the cystic changes and the tissue adjacent to it. And they say the placenta has a Swiss cheese appearance. So again, if you see a sac and you see this abnormal tissue, think about a partial mole. Frequently, they're misdiagnosed because people think, well, maybe that's hemorrhage in a patient that has a subchorionic hematoma. But again, the HCG titers will be helpful. And we're just going to finish up here with a couple of quick things. Here's a 38-year-old, 32 weeks pregnant with vaginal bleeding. Always want to take, once we get into the second, third trimester, always want to take a look at the cervix, part of our standard protocol. Here's the cervix here, and we notice that the placenta is crossing the cervical os. So this is obviously a case of placenta previa. It's a low-lying placenta that either comes up to the cervical os or can cover the cervical os. It occurs in about 1 in 200 pregnancies. We don't make this diagnosis before 20 weeks. So very frequently we can see a low-lying placenta in the first trimester, but we don't call it until after 20 weeks. And ultrasound and MR are both helpful. Here's a nice example of the MR, and the cervical canal is here, and we can see it's completely covered by the placenta. So there's a classification for previa. Class 1 is low-lying, where it's between half a centimeter to 2 centimeters from the internal os. 2 is a marginal previa, where the placenta comes to the edge of the cervix. Grade 3 is partial, where it partially covers the internal os. And of course, grade 4 is the complete previa. Here's some examples and a number of different ways to do that. You could do a transvaginal approach. Many centers do a translabial approach if they can't see well transvaginally. On the translabial approach, you can appreciate the cervical canal, can appreciate that there's this little lip of placenta that is covering the internal os. Transabdominal is not the best because it has a higher false positive rate than the other techniques. Here on the transvaginal view, you clearly can see the cervical canal, and you can see that the placenta, again, covering the cervical os. And here's just another example here of a patient that presents with vaginal bleeding and pelvic pain. And this history of pain and bleeding, certainly want to look around the placenta for evidence of bleeding. Here we see this large hematoma. Here's a different case here with this extremely large hematoma separating the placenta from the rest of the uterus. So these are examples of placental abruption. Again, you just need to do a survey of the uterus to be able to pick up these collections. These patients will present with pain. That is the classic triad of bleeding, pain, and uterine tenderness. Again, these need to be diagnosed early, particularly if these are large areas of abruption. They can be focal or they can be very large. Ultrasound has a relatively low sensitivity, but it has a high specificity if you see these large collections, as we do see here. MRI would be preferred in many cases, especially if it's equivocal, to confirm it, to help plan the therapy, and to characterize it. The last entity I'm going to show is this obvious example of cervical incompetence. Here we can see that the cervix is distended, it's filled with fluid, and it's shortened. And those are the things that you look for. In this example here on the right-hand side, we actually have a fetal foot that is projecting into this distended cervical canal. So cervical incompetence, painless cervical dilatation, occurs in 1 to 2% of all pregnancies in the middle, second, or early third trimester. It can be related to a congenital defect, or it may be acquired, typically a history of cervical trauma or infection. Again, we're looking for shortening and widening of the cervical canal, filling with fluid, bulging of the membranes, and the cutoff we use is 2.5 centimeters. If the length of the cervix is less than 2.5, then we say that it is incompetent. And of course, there's an increased risk of preterm labor. So with that, I'm going to conclude there's many causes of vaginal bleeding in a pregnant patient. Ultrasound is going to be our first-line modality. Patients to present to the emergency department. MR can be very helpful for further characterization of some of these abnormalities. And as I've shown you, 3D reconstructions can be very helpful in certain cases to look for evidence of interstitial pregnancy, to divine uterine anomalies, and other things that we may encounter. So thank you for your attention.